speak at this symposium on the diagnostic and therapeutic importance of cerebral microbleeds. I have no disclosures relevant to this presentation. It's a real pleasure to participate for the first time for me in a virtual symposium. Here you can see a reimagining of one of Charcot's famous demonstrations at the Salpêtrière Hospital in Paris, and it's a great pleasure to be with you virtually in Paris, and I'm sorry that we can't be together in person today. This is the structure of my talk. I will firstly give a brief overview of how microbleeds are relevant in small vessel diseases. Then we'll talk about microbleeds and the diagnosis of the arteriopathy underlying intracerebral hemorrhage. And then most of the talk will be about microbleeds and how they're relevant for the prognosis for intracranial bleeding risk. And this really is the most pressing question about microbleeds for clinicians. How can they or should they influence our antithrombotic or thrombolysis decisions in people with stroke? And then I'll summarize at the end. As you will all be very aware, bleeding in the brain, be that macrobleeding or microbleeding, is largely due to cerebral small vessel diseases, shown in this autoradiograph post-mortem brain specimen. We can classify small vessels into two broad networks. Firstly, a superficial network affecting superficial cortical arterioles, leptomeningeal arterioles, and principally affected by amyloid angiopathy. You can see here the deposition of amyloid beta protein in the walls of these small arterioles. The second system is a deep small vessel system supplying the basal ganglia and the deep white matter, and this is often termed arteriolosclerosis, but also can be known as deep perforator arteriopathy or hypertensive arteriopathy. And you can see the topography of these two processes could be reflected in the distribution of cerebral microbleeds, providing a basis for them to be relevant to the diagnosis of these conditions. I just want to put microbleeds in context. There are many neuroimaging biomarkers of small vessel disease. We've heard about white matter hyperintensities. I'm going to focus on microbleeds, but in clinical practice we must remember they're just part of this quite large and expanding spectrum of structural markers on brain imaging. Microbleeds are small, up to about 10 millimeter lesions. They're round or ovoid, and they're actually a loss of signal on a susceptibility weighted MRI sequence. And the typical sequences we use would be T2 star weighted gradient echo or dedicated SWI, susceptibility weighted MRI. And microbleeds have this blooming effect that I'll just show you now, whereby the lesion is hardly visible on a T2 but then becomes much larger on the blood sensitive sequence. And this shows very nicely how the microbleed is detected because of paramagnetic hemosiderin, which dephases the local magnetic field, producing a dropout in the signal. Microbleeds are generally due to small areas of bleeding from small vessels. We can detect between 50 and 90% of pathologically demonstrated microbleeds using MRI, but there are some false positives, including microdissections, microaneurysms, and microcalcifications. Onto the potential clinical relevance then of cerebral microbleeds. So I'm going to first talk about diagnosis and prognosis after intracerebral hemorrhage, and then we'll talk about bleeding risk in people with ischemic stroke or TIA treated with antithrombotics, and in patients with acute ischemic stroke who are being considered for intravenous thrombolysis. So with regard to diagnosis, strictly lobar microbleeds have good diagnostic accuracy for cerebral amyloid angiopathy, particularly in hospital intracerebral hemorrhage cohorts. And if we look at this table, we can see the original Boston criteria, which depend on strictly lobar hemorrhagic lesions in a patient over the age of 55 with no other cause of hemorrhage. And these original criteria, published in 2001, have pretty good sensitivity and very good specificity. When we apply them in non-hospital intracerebral hemorrhage populations, the sensitivity drops very substantially. If we add cortical superficial siderosis, shown in the panel on the right of the table, that seems to increase the sensitivity of these criteria without sacrificing specificity. But this was a very small study, and there's a large international effort taking place to modify the Boston criteria further and improve them in version 2, and we hope this will be ready by autumn this year. So why diagnose amyloid angiopathy in somebody with an intracerebral hemorrhage? Well, it's highly relevant for prognosis. This meta-analysis shows that if you fulfill those Boston criteria for intracerebral hemorrhage due to amyloid angiopathy, the risk of recurrent intracerebral hemorrhage is 7.4%, whereas those who don't fulfill that criteria, it's only 1.1%. And this is important prognostic information that's relevant for patients, doctors, families, and so on. The finding of markers of cerebral amyloid angiopathy is also relevant for dementia risk after intracerebral hemorrhage. We know that lobar intracerebral hemorrhage has a very substantial risk of future dementia, and this seems to be driven by markers of amyloid angiopathy, including microbleeds and siderosis. The establishment of CAA by the Boston criteria is also strongly associated with the risk of having had dementia prior to intracerebral hemorrhage. So let's now focus on the main topic of the talk, which is bleeding risks in patients with ischemic stroke or TIA and before intravenous thrombolysis. This slide outlines the main hypothesis by which microbleeds could predict future intracranial bleeding risk. Small blood vessels are constantly having small amounts of red blood cell extravasation. Usually leaks from the vessels can be contained by the coagulation cascade and then the action of macrophages to repair vessels and to mop up the blood degradation products, including hemosiderin. However, in the presence of fibrinolytic or antithrombotic drugs, one can imagine that what would have otherwise become a small microbleed that would be self-contained by these macrophages, instead, because of impaired hemostasis, grows into a large macroscopic intracerebral hemorrhage. So we hypothesize that microbleeds are a marker of bleeding-prone arteriopathies, which could help to predict this bleeding risk in clinical practice. So this is becoming a common clinical dilemma because we're using sequences that detect microbleeds very frequently now in clinical practice. And in someone with recent cerebral ischemia, the standard treatment will be usually to give antithrombotic drugs like antiplatelets or oral anticoagulants. And although they will reduce the risk of ischemic events from occlusion within the brain and other organ systems in the body, they come at the cost of hemorrhage risk, and the most devastating of these consequences, of course, is intracerebral hemorrhage or other types of intracranial hemorrhage. So we undertook a prospective inception cohort study to look at this question, specifically in people with recent ischemic stroke or TIA with atrial fibrillation who were treated with oral anticoagulation. We had about 2 years of follow-up in each patient, making 3,366 patient years of follow-up. We followed people up for symptomatic intracranial hemorrhage and recurrent ischemic stroke or TIA. And going on to the results, the rate of intracranial hemorrhage was low. We only had 14 symptomatic events. And with regard to the primary hypothesis that microbleeds might be related to intracranial hemorrhage risk, we did indeed find that in our adjusted model, the hazard ratio for microbleeds presence found that the adjusted hazard ratio is 3.67 compared to those without cerebral microbleeds, and that was in a pre-specified adjusted model. But of course, the most important thing is the absolute event rates, and we can see that even in those with more than 2 microbleeds, in other words, multiple microbleeds, the rate of recurrent ischemic stroke was substantially higher, 23.4 per 1,000 patient years, than was the risk of symptomatic intracranial hemorrhage, which was 14.4 per 1,000 patient years. But you can see, because of the limited number of events, these estimates were somewhat imprecise, and we had very few data on patients with many microbleeds, which in clinical practice caused the most concern. So we then wanted to address this clinical question of, does a large burden of microbleeds, or particularly that strictly lobar pattern suggesting amyloid angiopathy, does this identify patients who might have a higher absolute risk of symptomatic intracranial bleeding than of ischemic stroke, which would be highly relevant for antithrombotic treatment, because these patients might then be at net harm risk from treatment. So this is a large international collaborative effort, the Microbleeds International Collaborative Network, and you can see that there is good global coverage here. We included 20,322 participants from 38 cohorts, mean age 70, all with recent ischemic stroke or TIA, nearly 8,000 taking oral anticoagulants, and about 12,000 taking antiplatelet drugs. On to the main result, which found that there were microbleeds in 28% of participants. This included 226 patients with more than 20 microbleeds. We had a median follow-up of 1.34 years. There were nearly 1,500 composite events, and particularly noteworthy, there were 189 intracranial hemorrhages, mainly intracerebral, which gives us a lot more statistical power than previous studies. So the primary outcomes are shown here, and you can see that the presence of microbleeds is associated with an increased risk of all stroke. It's associated with an adjusted hazard ratio for intracranial hemorrhage of 2.45 and for ischemic stroke of 1.23. Notice we could adjust these for many more confounders than any previous study because of the larger number of participants. But the most interesting finding is, how did microbleed burden influence these events? And you can see for the composite outcome there was a clear graded relationship as the microbleed count increases. The orange curves are patients with 5 or more microbleeds. And you can see that for intracranial hemorrhage, the risk really seems to go up substantially with 5 or more microbleeds. For ischemic stroke, there's also a graded increase, but it's less steep, particularly when we get to 5 or more microbleeds, than there was an increase for intracranial hemorrhage hazard. Again, the absolute event rates are crucial here, and we can see them plotted in this table, which contains a lot of data. But essentially, the main result was that the risk of ischemic stroke was consistently higher than the risk of intracranial hemorrhage. So let me show you that. The absolute risk consistently exceeded that of intracranial hemorrhage, even for those with more than 10 microbleeds. You can see 64 versus 27 per 1,000 patient years. And even those with more than 20 microbleeds, these are the ones in clinical practice we're really concerned about, their risk of ischemic stroke was much higher than that of intracranial hemorrhage. This was also the case for all microbleed distributions, lobar, deep, mixed, or strictly lobar. And there was no interaction between the type of antithrombotic, ethnicity, and microbleeds. The results were consistent for those taking oral anticoagulants. So the clinical implications here are that microbleeds can inform us regarding the risk of intracranial hemorrhage and ischemic stroke in those with a recent ischemic stroke or TIA treated with antithrombotics, but the available evidence does not support withholding such treatment because of microbleeds. We are working on developing and validating simple risk scores for clinical use to help inform prognosis and treatment. Now finally, I'm going to talk about microbleeds before intravenous thrombolysis and this devastating consequence, which is intracranial hemorrhage after thrombolytic agents. Bleeding in acute ischemic stroke can be spatially associated with the acute infarct, that is hemorrhagic infarction or parenchymal hemorrhage, associated with reperfusion injury, blood-brain barrier disruption. And the second type of bleeding is remote from the infarct, which is more plausibly related to cerebral small vessel diseases or coagulopathy. Here's an example from the Berlin group showing a susceptibility-weighted MRI in panel A with multiple strictly lobar microbleeds, and then in panel B, after intravenous thrombolysis for acute ischemic stroke, we see multiple lobar macrohemorrhages, including one with a very clear fluid level. So the key question is, are microbleeds a predictor of intracranial bleeding risk after intravenous thrombolysis in acute ischemic stroke? This is a meta-analysis of nearly 2,000 patients from 8 centres, where we looked at microbleed distribution and burden on different patterns of intracranial hemorrhage after acute ischemic stroke, as well as on functional outcome between 3 and 6 months. Going straight to the main result here, you can see that microbleeds were associated with all symptomatic intracranial hemorrhage, and that the risk increased with increasing burden. They were associated with parenchymal hematoma within the infarct, and they were even more strongly associated with remote hemorrhage outside the infarct. When we look at distribution, we can see that both patterns related to amyloid angiopathy as well as not related were all associated with bleeding risk, but we can see there's a hint that maybe amyloid angiopathy is most strongly related to parenchymal hematoma outside the infarct remotely. So here we see that more than 10 microbleeds is associated with a poor functional outcome at 3 to 6 months, but not with mortality. However, this should not be used to withhold intravenous thrombolysis because these are non-randomized data and subject to bias and confounding. This paper, led by Christian Nolte and Ludwig Schlemm from the Berlin group, was a modelling study to look at the net clinical benefit of intravenous thrombolysis in acute ischemic stroke patients with a large cerebral microbleed burden, which are the patients that cause the most anxiety in clinical practice. And we use published data to look at the relationship between microbleeds, functional outcome, and also try to estimate whether it might be justified to screen for microbleeds in selected subgroups of patients. This was a complex modelling paper, and I won't go through the methods in detail because they're published and you can see them in the paper in Stroke earlier this year. Essentially, we looked at the odds of a good functional outcome, mortality, and the change in the utility-weighted modified Rankin score at 3 months as a measure of net clinical benefit. And we looked at those with more than 10 microbleeds compared to those with. We used published observational data that you can see listed here in the slide. This slide clearly shows that in those patients with more than 10 microbleeds, there was less chance of a favourable recovery with the modified Rankin of less than 2, and there was also a higher odds ratio of mortality by 3 months. This is the most important result that shows that those patients with more than 10 microbleeds consistently had less net clinical benefit, and this was statistically significant for older patients over the age of 80 with more severe strokes, which you can see on the right-hand panel. This slide shows the minimum treatment delays above which there is net harm in patients with more than 10 microbleeds, and you can see that the probability of net harm increases with age, stroke severity, and treatment delay. This slide shows for a 60-year-old patient with an NIHSS score of 5, the point estimate for net benefit of intravenous thrombolysis is positive only up to a treatment delay of 262 minutes. But for patients older than 80 with severer strokes, there is no net clinical benefit across the whole time window. When we modelled the maximum additional time to perform an MRI before thrombolysis, the maximum credible delay was 24 minutes, and for all patients under the age of 80, the maximum delay was less than 11 minutes. So I'd like to conclude that cerebral microbleeds are a validated marker of hemorrhage-prone small vessel disease. They're a useful diagnostic marker for cerebral amyloid angiopathy, relevant for the risk of recurrent intracerebral hemorrhage and dementia. They're relevant for assessing future ischemic stroke and intracranial hemorrhage risk in people with recent ischemic stroke or TIA, but even large numbers of microbleeds shouldn't lead to clinicians avoiding antithrombotic therapy based on present knowledge. Large numbers of microbleeds are associated with increased intracranial hemorrhage risk and poor functional outcome after intravenous thrombolysis, and 10 or more microbleeds can modify the net benefit of intravenous thrombolysis, but rapid MRI screening is generally not justified. I thank many collaborators. I thank my funders, and I thank you all very much indeed for listening.